So as I mentioned, I'm Meredith Davis. I'm the Behavioral Health Special Projects Manager here at the Colorado Department of Healthcare Policy and Financing, lovingly referred to as HICPUF. And we do at the state government, for many of you who know, we are very, very good at our second language of speaking in acronyms. So if we say an acronym with which you're unfamiliar, please don't hesitate to chat that you would like that to be specified for you. And I'll turn it to John.
Hello, my name is John Lentz. I'm the Wraparound Services Unit Supervisor, also at HICPUF. I'll pass it off to Megan Lee.
Good afternoon. I'm Megan Lee, one of the BHA Behavioral Health Administration Crisis Program Managers. And I think we have Zoe again today.
That's right. Zoe Bernard here with Manat. Thanks much, Megan.
And hi, everyone, I'm Gina Lasky, and we have some other folks on the phone from Manat and from HMA to help with note-taking and the Zoom. So thanks again for coming.
Okay, so thanks, Gina. So this slide is just a brief overview of what mobile crisis response is and what our two state agencies have been up to, sort of drafting this service definition. So what's behind this work is that Colorado in general is committed to operating a statewide crisis system that serves all Coloradans. So all the new mobile crisis response services will be available on a statewide basis, regardless of their health insurance status. Today, we're talking about a Medicaid benefit, but the development of this benefit is really the impetus to standardize and raise the standards for all mobile crisis response for all providers serving all Coloradans. So HICPUF and the BHA are collaborating to enhance the system, really building on the work of existing mobile crisis partnerships. We are planning to establish a new benefit under Medicaid, which aligns the ARPA requirements, national evidence-based, and leading state best practices.
And ARPA is American Rescue Plan Act. So we're working with the Behavioral Health Administration to take advantage of a federal option under this particular federal law that allows us to receive up to 3 years of an 85% enhanced federal match for community-based mobile crisis services that meet these federal requirements. And we'll be talking about that in more detail. Excuse me. The initial benefit design is also being informed by stakeholder feedback, as well as an assessment that was done a few months ago, looking at the current Colorado crisis system, and stakeholder feedback, including from you here today, as well as some of our other stakeholder opportunities, is going to be integrated into our final design to really make this a Colorado plan. And our goal is to launch the new benefit July 1 of 2023.
Some of what we're hoping to accomplish with this new benefit is to improve the quality and consistency of mobile crisis services for Coloradans experiencing a mental health or substance use crisis, reduce ED visits, inpatient hospitalizations, and arrests of folks who are in a behavioral health crisis, enhance efforts to connect folks to ongoing community-based mental health services and other like non-traditional supports, strengthen provider capacity and expertise to make sure that the response works, including for members of targeted populations that we'll review in subsequent slides, increase the public awareness of mobile crisis services and how to access them, and integrate this benefit into our other work, like the rollout of 988. So we have worked with a wide variety of stakeholders and community partners, really with the intention of honoring existing mobile crisis partnerships, including the role of law enforcement and co-response models, which we know are really critical in many communities. We also want to consider that Colorado has a unique geographic landscape and that flexibility is needed across rural, urban, and frontier communities. in order to come up to capacity to meet the new requirements. We also want to better meet the needs of all Coloradans, including individuals with IDDD and other cognitive needs, children, youth, and their families, and tribal members. And then we also want to integrate mobile crisis services into the care continuum, including better access to secure transportation in coordination with follow-up care and social services.
The MCR service definition is, this is the overview of MCR service definition. HCBUF and BHA, again, Healthcare Policy and Financing, and the Behavioral Health Administration have worked in partnership to develop the draft MCR, or Mobile Crisis Response Service definition, which outlines the service description and the provider requirements. The MCR service definition aligns with federal requirements under the American Rescue Plan Act, or ARPA, CMS, or Centers for Medicare and Medicaid Services, guidance, and national evidence-based best practices for mobile crisis services. The MCR benefit was designed based on a 6-month iterative process so far, drawing from a comprehensive assessment and gap analysis of Colorado's current mobile crisis system and the policies therein, 30+ interviews with a wide variety of stakeholders from all across the state, feedback from a mobile crisis work group that began meeting regularly in February, recommendations from SAMHSA best practices, and recent efforts by other states who are also using ARPA funding to see what they're doing and see what we can take in. The HCBUF and BHA are soliciting stakeholder feedback. Thank you everybody for showing up today. This is great. We're soliciting feedback on the draft MCR service definition. Stakeholder input will be integrated into the final MCR service design to ensure that the mobile crisis services meet the needs across the entire state.
All right, the next several slides are going to go over the actual components of the service design. So really what the requirements will be for mobile crisis providers and what the community can expect. Sort of from pre-engagement to all the way through follow-up and what happens after the engagement. So the providers will work with their ASO, which is Administrative Service Organization, what our office, the entities our office contracts with to procure mobile crisis services in each region. So the providers will work with their ASO to build a community engagement strategy, provide outreach materials on mobile crisis services to stakeholders that might interact with an individual in crisis and or the crisis system. And all of these efforts are in addition to marketing efforts coordinated by our office. We will work together as a state with all of our providers and the hotline to develop dispatch criteria, really building on what's already in the provider manual, but just with making it a little more robust and enhancing it and making sure everyone's on the same page so that when a dispatch is requested locally or through the statewide hotline, that all requests are responded to and that everyone is using consistency in criteria. And then the provider will document dispatch and disposition information in the dispatch portal for all mobile crisis response, regardless of their referral source. So then when the actual encounter happens, the initial crisis response must be face-to-face and where the individual is in the community. Follow-up can be in person, via video, telephone, sort of up to the provider and the individual in crisis. And all activities should last no longer than 5 calendar days, including the initial crisis response and follow-up. The risk assessment that providers currently do, the 20-point assessment in rule, is going away starting in July. or that's our plan at least, when we do rule updates. And really making the risk assessment more crisis oriented. So in line with national best practices, which will get rid of the full psychosocial and really focus on a safety, needs, and risk assessment. That assessment will inform what the intervention and stabilization looks like, but it's really intended to maintain stability in the community and avoid a higher level of care referrals. The team should provide harm reduction interventions like the administration of naloxone to reverse an overdose if needed. And then the team should develop crisis safety plans in collaboration with the individual in crisis and whatever relevant social supports are there with them, and should include advanced directives.
Thanks, Megan. And I do also just want to point out that the initial crisis assessment being done face-to-face is a federal requirement and is also listed as a best practice, which I believe Gina provided some of the links in the chat to some of the best practice documents. We also received an option to include harm reduction strategies like naloxone administration from the Center for Medicare and Medicaid Services, and we chose to exercise that option because we have had such a pretty widespread push to expand naloxone availability here in the state of Colorado. In terms of follow-up activities, the immediate follow-up activities need to be happening within 24 hours and then up to that 5 calendar days. And that really will include the individual and any relevant social supports or personal supports that the individual identifies. And that can happen in person or via phone based on the clinical need and the individual's preferences. The follow-up crisis response, so following that 24 hours, kind of the, setting them on the continuum of care, those follow-up crisis response can be conducted face-to-face, via telehealth, or via telephone only, again, based on clinical need and preferences. Mobile crisis teams are going to be responsible for ensuring that referrals and warm handoffs are happening to social and health services and supports as needed. The initial contact, as we mentioned, needs to be made within 24 hours of the face-to-face intervention. And then the mobile crisis teams need to attempt to schedule an appointment from that referral within 7 business days of the referral being made. We understand that some folks may not opt in to have or accept that referral. It may not be relevant for a few occasional folks, but we understand that there is sort of varying availability of treatment providers. So we need the attempt to be made to have that appointment scheduled within 7 days of the referral. Then the mobile crisis teams also need to make sure they're coordinating with the individual's administrative service organization, regional accountable entity, and or behavioral health provider to really capitalize on the opportunity for continuity of care after that 5 calendar days. And the mobile crisis providers also will be working with the ASOs and the RAIs to develop and maintain relationships with whoever is giving them referral sources or providing them referrals to mobile crisis. That includes schools, law enforcement, behavioral health and other crisis service providers, and specialty facilities like psychiatric residential treatment facilities and qualified residential treatment programs. And I'm going to turn it to John Lentz to talk about secure transport.
Secure transport. MCR teams will be required to provide or coordinate clinically secure transportation between levels of care through the crisis episode. This is really important to have this be administratively separate from the other MCR activities. The secure transport will be recorded, understood as, and paid for separately from all the MCR activities. So that all of the de-escalation and all of the immediate crisis care situational response things, that is part of the MCR. The transport itself is separate. The MCR teams are responsible to either provide or coordinate it, but not, it is a separate thing. So providers can wear many hats, but they would, yeah, they're not the same thing. I feel like I'm saying that too many times in a row, but we'll go to the next slide. The relationship with intellectually developmentally disabled, traumatic brain injury, severe mental illness, severe emotional disturbance, co-occurring disorders, and cognitive needs service providers. The MCR staff must also be trained in responding to individuals with these needs and other cognitive needs or neurodiversity who are in crisis. And MCR providers will collaborate with their ASO and must develop contractual relationships with local providers with expertise working with the populations referenced above. These providers must be engaged during or immediately after the initial face-to-face intervention as needed to support individuals in crisis who do not already have an existing relationship with a provider, and telehealth may also be used to secure this expertise during the crisis.
Great. I'm going to let Megan talk about the licensure requirements, and then I'll talk about team requirements.
Sure. So currently our system works like the ASO contracts with the provider, and then once the provider is like sort of in the network, we do some licensure and designation oversight. When the behavioral health entity was created, it was under the Department of Public Health. That's going to move back under the purview of the BHA. And when that happens, the order of things will likely be in reverse. So the BHA will sort of pre-approve a set of providers that the ASO then will be able to contract with. When we pre-approve, that means that the providers have met all of these requirements and whatever other like provider type requirements there will be. And then the ASO can contract in the context of this conversation with the provider to do mobile crisis. So we'll have this readiness review process for this benefit that we'll work on up until go live in July of next year. And then after July of next year will be when we start taking over the BHA process at the BHE process at the BHA. As Meredith said, we sometimes talk in alphabet soup. So whatever we go through for this readiness review process, we hope will be very streamlined into whatever eligible providers getting their crisis behavioral health entity license type with a mobile crisis endorsement. And then after this year, when the timing is a little funky, that'll be just a yearly thing where we ensure that all of the mobile crisis providers meet these standards, and as such are eligible to become a crisis provider type with a mobile crisis endorsement. So it will be just one process in years to come, and they'll be identical. One sort of implies the other.
Thanks, Megan. So each mobile crisis response team needs to include multidisciplinary professionals and paraprofessionals. The initial mobile crisis response must be from a paired response team from 2 members of the mobile crisis response team that has dispatched. Follow-up visits to continue stabilization, coordinate care, and make referrals can be done by a single member of the mobile crisis response team. That initial crisis response should be a paired response. Mobile crisis providers can request an exception to the initial in-person paired response. If an exception is granted, one individual must provide the initial response on site, and the other team member can participate using telehealth. This is intended to offer some flexibility in the face of workforce shortages and understanding that not all teams may have, for example, clinicians readily available. So we will be working with providers on when this exception can be sought and how to do so. Next slide, please. So in terms of mobile crisis staffing requirements, the mobile crisis providers can include a variety of trained professionals on their teams. That can include behavioral health clinicians, social workers, EMT or community paramedics, peer support specialists, mobile crisis case managers, nurses, and other trained crisis staff. We are going to be, sorry if there's a horn honking in the background. We are going to be working on, and Megan will outline the change in the definition of a skilled professional. As far as a licensed clinician, every mobile crisis team must include a licensed clinician or have a licensed clinician immediately available via telehealth. Again, recognizing workforce shortages, we want to make sure that's still available, but that person may not necessarily be required to go out in the community with that team. And the paired response can be a different pair of folks if they have access to that clinician. Every mobile crisis team should also have access to a peer support specialist who can be included in the mobile crisis response team. And that person could take the lead on initial engagement and also help assist with follow-up services and ensuring that continuity of care. The mobile crisis teams also need to include a staff member who has specific training and expertise in serving children, youth, and their caregivers who experience crises. That's definitely been an area that we have been told is not necessarily meeting the need of families in crisis. So we are going to be requiring specific training, and we'll talk about some of that training here in just a bit. And then mobile crisis teams may also utilize an emergency medical technician, excuse me, or paramedic with the endorsement of a community paramedic that aligns with, or excuse me, in alignment with the Community Integrated Healthcare Service Agency working with the mobile crisis team. If you're interested in more information about that option, we can certainly have a separate conversation. We can answer some questions later in this session or in the breakout rooms. And then we can also give you some examples of teams that are operating under this model and how they've been successful. I'll let Megan talk about the skilled professional change definition.
The current requirement for sort of the person that has to lead the crisis intervention and assessment is a skilled professional, which we've defined as someone with a master's degree in a relevant field like social work or counseling. We're hoping to change that definition to simply someone who has had approved training in crisis intervention specifically. So really recognizing that a master's degree doesn't necessarily confer crisis specific skills, can be really hard to hire those folks. And we want people to feel more trained up and competent in doing crisis specific work. So the sort of lead, the clinical lead in the pairing will still be a skilled professional, but the definition of that is going to hopefully change as we do rule revisions in the next upcoming year. Next slide. So with that, the BHA is launching a learning management system. We would hope that eventually the crisis specific training to sort of become an approved skilled professional will be housed on that. But certainly the standardized already required trainings that you see here will be housed on the learning management system so that everyone is getting the same training and we track completion of trainings in one centralized location. Next slide. Currently, our providers are, each provider is required to be available 24/7, 365. This will change slightly in that there will still be a requirement that every county in the region has 24/7, 365 coverage, but that it's region-based instead of provider-based. So this will require a little bit more oversight and monitoring on the part of the ASO to track volume and needs in the region and figure out how to kind of stack teams or staff teams to account for the needs of the region. An example of this would be like if a certain area has higher volume on Friday and Saturday nights, we could have the ASO overlay a team on top of the existing team just to cover those Friday and Saturday nights. Whereas our current requirement would not allow that because every provider has to have 24/7, 365 coverage. So this just lets us be a little more nimble and responsive to the needs of the region. We will continue on with our 1 and 2 hour timeliness requirements. So 1 hour response times in metro areas and 2 hour response times in rural and frontier areas. And then all responses, this is a federal requirement, all responses have to happen in the community or in the person's home in order to be reimbursed through Medicaid for this benefit, for any reimbursement, and for the enhanced federal match. We know that many of you have really important relationships with other entities and facility types. And so the BHA is coming up with a plan for how we will allow CCS dollars to continue funding some of these community facility-based responses when the federal requirements disallow reimbursement to those locations. So stay tuned for more information on what exactly that's going to look like. And I see some questions, and do we want to save even the one for the end, Gina, about going back to the last slide?
You can go ahead if you want. I'm happy to go backwards.
Yeah, we can. You want to just pop that last one back up for a second so that Lori can take a look? So this list doesn't include training specific for people with IDD in crisis, but CCS requires some training for special populations that will be posted on the learning management system. And there will also be some other initiatives, like John mentioned, partnering with like IDD specific providers to make sure that the quality of care is improved. So we'll answer more questions at the end, but I just wanted to give Lori a chance to take a look at that slide really quick. Okay, I'm done with this slide too. All right. John, I think that's you.
It definitely is me. Use of telehealth and other technology. Telehealth for the initial mobile crisis response may only be provided when there is one member of the MCR team in person, and the MCR provider requests and receives permission from their ASO to provide telehealth. This is specifically not meant to be a barrier. This is meant to assure that this can be done. Because the department, the BHA and HIGPUF enforce against the ASOs and the RAIs, not against the providers in this case, we do need to have the individual providers work with the ASOs to assure that these things are able to be happening. Other technologies should also be accessible to providers when needed to ensure mobile crisis teams are able to communicate with all individuals in crisis, including individuals who are deaf, hard of hearing, or deaf-blind, such as CART services, closed captioning, video phone, amplified and captioned phones, smartphones and tablets, and other augmentative and alternative communication devices.
So we've just spent some time talking about what the actual sort of crisis response from start to finish looks like. The next several slides will talk about sort of what the system will look like moving forward in our partnership. So the BHA and HIGPUF are partnering. BHA will continue to oversee the full crisis continuum of services and partner with HIGPUF to oversee the delivery of mobile crisis services. Every Coloradan will have the same service and equal access to this high quality set of standards. The ASOs will continue to establish the mobile crisis provider network as they have, and the RAIs will work with the ASOs to make sure that there's adequate network in place for Medicaid beneficiaries.
And they're reporting to and from mobile crisis providers, the administrative service organizations, the regional accountable entities, the Behavioral Health Administration, Healthcare Policy and Financing, and the Colorado Crisis Services statewide hotline or 988. They're going to be streamlined. Basically, what we would like is that everybody is carrying some of the reporting and data sharing version, and that the bulk of it is not falling on providers. So we really want providers to be able to focus on delivering services. The RAIs, or the regional accountable entities, are responsible for the provision and oversight of these mobile crisis services, consistent with other services offered. And that includes contracting with mobile crisis providers and working closely with the administrative service organizations to ensure network adequacy. And the raise will also provide reimbursement for mobile crisis services delivered to Medicaid beneficiaries. And under the enhanced or expanded benefit, we are going to be adding additional billable components to the mobile crisis response so that it is a more sustainable, fiscally sustainable opportunity. So in doing so, with adding some additional billable services to the mobile crisis in the initial response, as well as the follow-up, we are asking that mobile crisis providers take up their part of that responsibility for seeking reimbursement from the appropriate payer, and especially from the raise for Medicaid beneficiaries. So we want to try to provide more fiscal sustainability and offer more billable services, but we also need mobile crisis providers to commit to billing fully for all Medicaid reimbursable services from Medicaid, and also seeking reimbursement from other payer sources as applicable. Next slide. All right, so in terms of, pardon me, in terms of some of the reporting and some of the burden and the contracting, and if this text is too small, again, there's information in the chat about how to access these slides on your own through the BHA website. The BHA is contracting with the ASOs and Colorado Crisis Services. They'll develop and adjust the budgets for those two entities and do so every year here on after. They will conduct the provider readiness reviews and manage the provider training with the learning management system that Megan was referring to. And then they'll be determining the number of mobile crisis teams necessary to ensure 24/7, 365 coverage and a timely response. On the other hand, HCPF is responsible for contracts with the raise. We'll develop and adjust Medicaid mobile crisis rates and billing guidance for providers and for the raise. We will be responsible for securing Centers for Medicare and Medicaid Services approval for a new mobile crisis benefit under Medicaid, which will also be written into a state plan amendment, making it part of our standard service delivery. And then we'll develop and submit a budget request to the state legislature to make sure that this is an ongoing supported benefit statewide. Colorado Crisis Services, a statewide hotline, or 988, which we're using interchangeably. They'll serve as the centralized statewide crisis line. They will screen crisis calls for level of need and dispatch mobile crisis providers in the event that that is the appropriate disposition for that crisis response. They will be responsible for providing data on calls and response time to the ASOs and the BHA, which is a component they report on now. The ASOs will need to contract directly with crisis providers to provide them general state funding that will supplement what is not currently billable under Medicaid. They'll ensure network adequacy for non-Medicaid beneficiaries and for the crisis system statewide, and they'll pay for non-Medicaid mobile crisis services. And as they do now, they'll submit aggregate measures to the BHA. The raise on the other side of that coin are contracting with providers specifically for Medicaid beneficiaries. They'll pay for Medicaid mobile crisis services and ensure network adequacy for Medicaid beneficiaries statewide. And they'll submit encounters and claims to HCPF as they do now. Part of what we are going to ask is that the ASOs and the raise commit to a strong partnership that really works to support providers, let us know of any provider performance issues and how we can support and troubleshoot and provide technical assistance. And they're going to need to share data back and forth and with the mobile crisis providers and with HCPF and the BHA on key measures and encounter information. So finally, the mobile crisis providers are going to do the provision of services in their service area. They'll contract with their ASOs to offer mobile crisis response services, complete all the required training and the readiness review, submit mobile crisis encounter information to the ASOs and the raise, submit Medicaid claims to the raise for billing, and then submit data to the statewide hotline via the mobile dispatch portal, which is something that is currently occurring. Next slide. So in covering our timeline, we started this process in earnest in January. January through April, our partners at MNAT helped us do an assessment of the current Colorado crisis system and conducted key stakeholder and key informant interviews. We also began convening a monthly working group that has representatives from a wide variety of stakeholder groups. They meet monthly to inform on the service design and some of the specific components we need to consider for Colorado as a state, as well as communities within Colorado and how they might differ. They'll be meeting at least through September, and we're looking at how we might repurpose that meeting to continue to offer support to providers. We are currently in the period of stakeholder engagement, and thank you all for being here and being a part of that with us. We want to gather feedback on the proposed design and really understand what people's concerns and questions are and how people think that they will be most successful. And we'll be incorporating that into the final service design.